He's going to talk about I have problem without RCTs and only physiology. So, Rinaldo, please.
Thanks very much, Yuka. I love physiology, particularly renal physiology, so I will let my children play with children of physiologists. But today I am here as a trialist in a meeting about physiology. And what I propose to do is to say lots of things that will upset a lot of people. They're very controversial, and I do that for effect. And I hope that it will trigger a lot of sort of discussion and a lot of opinion and a lot of emotion. So the issues I'm going to discuss today have been with us for a long time. And they go to the core reason why we do empirical trials. And it's the fact that Leonardo da Vinci noted very long ago that we all love our own opinions in a way that is really problematic. But also it goes to the concept about what we know and what we believe to be true and how science changes that all the time. This is what I used to study when I started medical school, Harrison's textbook of medicine, and they had all the things you should do about myocardial infarction. So you should rest people in bed. That's how Dwight Eisenhower was treated when he had his myocardial infarction. You really don't want to strain because the Valsalva maneuver will kill you, so you can't go to the toilet and get out of bed to do that. We will not give you beta blockers because the heart's suffering and it needs to contract. And if you've got ectopics, you've got to treat them with a lignocaine infusion. And more importantly, if there is myocardial infarction, there's going to be a clot in your coronary vessel. We really don't want to touch that. So no angiography for 6 weeks. And of course, this is all due to lack of oxygen, so we're going to give oxygen to all patients. So it's not long ago. I mean, this is about, 40 years ago, a little bit more. It's all gone. We laugh at this. Everybody was giggling. But the doctors then would have stood up here and would have preached to you that this was what should be done. So, are we different in critical care? Well, let's talk about it. Let's talk about sepsis. We have this mother of all physiological beliefs that hypoxia is really what drives cell injury in sepsis. It's a concept, it's a framework, it's a paradigm, it's an ideology. We don't actually know if it's true. We don't know whether cells actually die or are injured or malfunction because of lack of oxygen or because of immune-mediated cell injury. We don't know, but we've decided it's all about oxygen. And because we think that way and we create these physiological paradigms, then we do interventions like early goal-directed therapy. Because the plausibility of increasing oxygen delivery in terms of cell protection is so high, it's got to work. And then we had this trial, and even though the trial logistics, the design, the single-center nature, the fact the protagonist was looking after the patients, created immense biases. Everybody wanted to believe that. Recently, we've had the vitamin C story, just the same. Everyone wants to believe it. And then trialists like myself had to spend a decade trying to undo the consequences of such thinking. And we have to spend a lot of money, millions of dollars, and we have to get 15 times as many patients to demonstrate that physiological belief driven by a small trial equals bullshit. There are a lot of paradigms in medicine that are promoted by physiological thinking. Glucose levels are high in intensive care. They're associated with mortality. We've got to make them normal. Protein C in sepsis is low. It's associated with mortality. We've got to give protein C. We have oncotic pressure, which is low. If we gave albumin, the edema will go away, and that's really good, particularly for the brain. Very high intracranial pressure is associated with the risk of death. We've got to make it go down, and everybody will be happy. Let's decompress the skull. Let's go through each and every one of them. So we should go for normal glycemia because it's really good for you because it's associated with better outcome. This is a nice trial. Of course, it's the other way around. The more you pursue normal glycemia, the more you hurt patients. This is a positive trial. It shows what you should not do. If we had not done it, the concept of intensive insulin therapy would dominate all over the world, and God knows how many people would have died. Protein C in sepsis. Levels are low, we give it, we make everybody happy, we spend $15,000 a pop, and everything will be okay. It's because we do the trials that we find that, in fact, you increase the risk of bleeding. It doesn't really do anything for patient outcome, and you save a lot of money. It's a positive trial. It stops you from spending money on stupid things that don't do anything for the patient. Albumin to decrease edema must be great. So we did the SAFE trial, and we looked at patients with traumatic brain injury. I can still recall, and this is really important to me, I can still recall, I had the results of the SAFE trial in my pocket. I was in Sydney. We had a meeting of all the investigators, and I said, okay, which subgroup do you think that albumin helped the most? 80% of the doctors raised their hands. We know, traumatic brain injury. Albumin, we had the Lund protocol, there's decreased cerebral edema. Albumin is best for people with traumatic brain injury. They were wrong. And this is a wonderful description of the power of opinion and thinking without empirical evidence and the importance of trials. This is a positive trial. This is a positive trial. And the thing is that people thought about albumin on clotting pressure, and they didn't even think, or they didn't even reflect that the albumin solution that we sell in Australia is slightly hypotonic. And if you give it to people with cerebral edema, as you can beautifully see that in the comparison of what happened to ICP in those that had ICP monitoring versus those that got saline, you induce massive rapid surges in ICP. So you can even study that in animals. I'm a physiologist as well. You can make albumin that is isotonic, and you can take the commercial albumin, which is slightly hypotonic. You can give it to sheep with an ICP monitor in place, and these are normal animals, and you can see very nicely what happens when you give the hypotonic albumin to the intracranial pressure of a normal animal. Just imagine what would happen if you had cerebral edema. Okay. ICP, if it goes up and up and up, it kills you. So what we need to do is take the skull off in people with diffusive cerebral traumatic brain injury, and the ICP will go down. Absolutely true. Physiological success. I mean, this is the mother of all physiological success. I mean, look at this. It's fantastic. Pity that the patients went home with more brain damage and decreased cognitive performance. So we achieved physiological success like never before, but the patients did worse. And you might say, how could that happen? Think about it for a moment. You've got the brain with an ICP of 25. You take the vault off. What's the brain going to do? It's going to pop out. And what's that going to do? It's going to tear all your axons forever. And you will not recover. Right? Okay, more physiological paradigms that drive clinician behavior. Critically ill patients have increased caloric expenditure because of their illness and their stress factors. We got to feed them. They got low glutamine levels because they use it up like crazy. We've got to give them glutamine. Okay, let's go into it. Early versus late parenteral feeding to make people receive the adequate nutrition that they need because they consume calories. So the comparison of late versus early nutritional intervention. And if you give them the calories they need and you have early initiations, you got delayed discharge from ICU, delayed discharge from hospital, and you have more problems. No advantage, more cost. This is a positive trial. I know what you're going to say. Yeah, but it's because it was TPN. No, if it was enteral, it would have worked. It would have been just fine. Really? Really? Okay, this is just out of the French group, the Nutriria 2. People on vasopressor drugs randomized to early nutrition given enterally versus parenterally. You know, the dogma is we've got to give it enterally. It's really cool, okay? And that's what was done. So if you get nutrition enterally, things should be just fantastic. But they're not. But they're not. It's a damn illusion. Look at the bottom of the gastrointestinal complications. You make them vomit more. You make them have more diarrhea. You increase the risk of bowel ischemia. You increase the risk of pseudo-obstruction. So all this theoretical framework that we believe in, that it's more physiologic to feed people enterally that are very sick, is bullshit. Right? It's bullshit. And this is a positive trial. It uncovers the bullshit that we live and die by without empiric evidence. Okay, feeding is absolutely necessary. It's a priority. We've got to give people food. It's really important. We all go to McDonald's or something, so we've got to do the same for our patients. Really? This is the Eden trial. Okay. So patients with ARDS, 1,000 patients randomized to nutritional intake according to calculation of expected caloric expenditure versus trophic feeding, 20 meals an hour, just because they couldn't get it through ethics to give nothing. So they had to do something, right? So that must be a terrible thing to do. You're starving the patients for a whole week who've got ARDS. Absolutely not. It doesn't make any difference to anything, except for the fact that these patients, again, had more vomiting, more hyperglycemia, more prokinetic agents. Glutamine, another construct. They're all glutamine deficient. You can demonstrate they've got low glutamine levels. And if you gave glutamine, you make their glutamine levels go up. You're replacing it, but you just kill people. That's a problem, isn't it? Patients don't really care very much about their glutamine levels. They like to go home alive. More bullshit. The target trial. We're not giving enough calories. That's what it's about. Because they don't tolerate the feeds, and in the end, we only end up giving 60% or 70% of what people really need. All we have to do is give an energy-dense preparation that's got 50% more calories so that people actually get what they should get, what we think they should get. And this is the target trial. You can see clear difference in intake of calories. That's wonderful, and it made no difference at all. At all. Right? It's, again, a construct that has no empirical basis. Well, fluids. I mean, wow. Fluids are the mother of all physiological ideas. You've got to resuscitate people that are septic with lots of fluids. Really? Let's take the white man's medicine to Africa. All these people in Africa, they wouldn't know what's good for their kids. We know because we are from the West. Let's do it. Let's apply the Society of Critical Care Medicine guidelines to the resuscitation of septic children in Africa. There it is. That's a FEAST study. Almost double the mortality of these children. The best one in our world is starch. I mean, who came up with the concept you can squash potatoes and turn them up into something and put them into fluid and give it to human beings, and that's a really good thing to do? I mean, who came up with that? Unbelievable. Okay. Because large colloids are best. That's what we need to do. They will retain fluid in the circulation. They will stop edema. They will save lives. Really, this is Anders Perner's study, the 6S study, increased mortality. Another positive study which should have led to the cessation of marketing of starch, but it didn't happen. So we did the chest study in people having surgery, and just like in Anders' study, we showed that there was an increase in renal failure in the patients receiving starch. A thing that's been known for some time. Do you think that this would have stopped the marketing of starch or the use of starch? Hell no. This is in JAMA 3 weeks ago. This is a randomized trial of hydroxyethyl starch in people having surgery. Again, we did the same thing. They did the same thing, and we get the same answer. More acute kidney injury. The 6S study, more acute kidney injury. Chest study, more acute kidney injury. The FLASH study, more acute. It goes to the behavioral clinicians. What the hell do you need to have to stop giving starch? I mean, you're spending something that's 15 times more than crystalloids to buy yourself a product that increases acute kidney injury in 3 randomized double-blind controlled trials. What do you have to do? It's an extraordinary thing. So, are doctors particularly stupid? Well, actually, maybe. But let's be fair to doctors, because you might come to the conclusion that they might be evil. But it's because they have to make decisions. Every day, they have to make a decision about everything that they do. So in a given patient, they might make 10, 15 different decisions. And they can't tolerate the concept. It's really difficult emotionally that they actually have no idea what they're doing. At a deep level. They do at a certain level, but at deep knowledge, they don't know what they're doing. We don't know. I don't know what I'm doing. At a deep level. And physiological gain, it's so seductive because you can see it. It happens right away. It's like somebody winking at you. Hi, come and see me. Why do we do this? Right? Because we're seduced by a variety of biases. The first one is attribution bias. That's the anecdotal and selective observation of victories after an intervention, which leads to undue confidence in its effectiveness because we forget all the failures we don't want to remember. And physiology does that all the time. It winks at you, and people love it. And then it winks again with immediacy bias. What the hell is immediacy bias? It's the immediate observation of a favorable effect which you attribute to the intervention because you're going to use attribution bias. And then you put a lot of weight on the changes you've just seen rather than on the changes that are either invisible because you're not measuring them or are going to happen in 3 hours' time when you're actually having an espresso in a cafe down the street. Right? And so it's wonderful. It's the trickery. It's like magic. And people love it. Let's talk about IV fluids and immediacy bias. We give IV fluids to people after surgery to replace the losses. We give boluses of fluid. We love it. They think they've got great value. Are we dealing with immediacy bias? If you look at all the data on the administration of fluids and fluid effectiveness in generating a response, okay, and you look at all these papers, when you look at the response to fluid bolus and you look at when it was measured, have a look at that time from end of bolus, which is telling you when it was measured. Look at that. After the bolus, immediately after the bolus, immediately. One study at 30 minutes. Look, all immediately after the bolus. Well, what happens in an hour's time? Oh, we don't care. We don't really want to know. Look. It's all bullshit. Now, this is in a group of 30 patients after cardiac surgery where we didn't do anything. We didn't do anything. Right? These are cardiac surgery patients where clinicians said, they're hypotensive, I'm going to give them a fluid bolus. Okay. So we just connected the computer to the monitor and just downloaded the blood pressure. Right? Bingo. The blood pressure was 0, which is the baseline. That was the baseline was labeled 0 in this graph. People gave the fluid bolus. You can see the blood pressure went up on average about 8 millimeters of mercury. And the doctors walked away after 3 or 4 minutes because, hey, it worked. It was fantastic. God, thank God I did it. Thank God I did it. Fixed the blood pressure. Except that at 30 minutes, you're exactly back to where at the beginning you were. So what are you going to do? You're going to do it again. Okay. And then you're going to do it again. Okay. And then you're going to do it again. Okay. So when are you going to stop? What are you going to do for the next 22 hours? Right? Stroke volume. Don't worry, it's the blood pressure. It doesn't matter. It's okay. We've increased the cardiac output and we increased the stroke volume. This is in the same patients. They had continuous cardiac output monitoring with a Swan-Ganz catheter. Look, bang. 20 minutes, 20 to 25 minutes, hasta la vista. It's gone. Right? So, but this is what people were excited about. In any case, Just let me ask even a harder question. Did the blood pressure go up because you gave the fluid or because you put something that was 20 degrees into the veins of the patients? Right? Because the data is that if you give cold fluid versus warm fluid, there is a clearly different effect on blood pressure. So you might even think that's due to the fluid. Maybe it's not even due to the fluid, and it's the fact that you put something cold in the veins and you trigger a noradrenaline release. So, the problem with physiology is short-term observations. You only measure the things you're interested in. You have no idea of the unmeasured variables, because if you could, you would measure them. The assessment is usually assessed for a very short period of time, not independently adjudication. Normalization is obsessively considered desirable, which may not be true, and you have all sorts of limitations in understanding what actually happens to people. And this is what I call the physiological knowledge illusion. But then there is another one that I really love. This is from psychology. You've got to listen to this. I absolutely love it. It's called overclaiming bias. These are psychological experiments that show that people, and in this particular case, doctors, overclaim their ability to know and their actual knowledge to the extent that they perceive themselves to be experts, like me. All right? And it's fascinating. These are psychological experiments, and they're totally irrelevant to what I'm talking about. People in psychological experiments claim knowledge of things that don't even exist. It cannot possibly be known. But if they believe themselves to be experts, like about basketball, then they can overclaim it even more when you ask them about Kobe Bryant. Oh, yeah, he played for this team. Yeah, I know because I'm an expert. It's fascinating. And warning people that something you're going to ask them about, right? The concepts are possibly false. It doesn't stop them. They continue to overclaim. All of us are geared to bullshit, right? We are hardwired to bullshit. That's why politicians are so successful, because we bullshit to ourselves every day, all the time, relentlessly. Right? And these guys in the psychological test were given names of cities that didn't exist, but because they had just been boosted with some information that they were really good at geography, they would overclaim that Samarkand was the capital of Illinois. Right? They would do it. It's a thing we do. It's a characteristic of what we do. And this introduces a very important concept, rational astrology. And this is what most of what we do in clinical trials and physiology, it's rational astrology. We behave in a particular way based on beliefs about the way we think reality is, irrespective of whether there is robust empirical evidence that what we believe is true. We're indifferent to it. It doesn't matter. Now, sometimes the beliefs that we have might turn out to be true. That'd be nice. But that's not really important, because the beliefs that we have are what drives our behavior more than the empirical evidence. And that is one of the reasons that we can't get doctors to do prone positioning, because their behavior is driven by their own internal rational astrology, not by empirical evidence. And indeed, the whole world swims, bathes, showers in rational astrology. You know, my mom used to tell me breakfast is the best meal of the day. No, I would never upset my mom by saying, Mom, where is the randomized controlled trial to tell you that's true? Says what? And by the way, what's the outcome measure? Come on. And of course, all of politics is rational astrology. All ideology is rational astrology. So let me finish by saying that it's not what you don't know that gets you into trouble. It's what you think you know for sure that just isn't so. But don't worry, it's okay, it's okay. Let me conclude by saying it's okay, because all these things that I've just told you about do not apply to you. They've got nothing to do with all the doctors that are here in Prague, because I know that you read all the relevant physiology literature in detail. You consider issues of biological plausibility. You follow carefully evaluated evidence. You're open-minded. You're balanced. You're thoughtful. You're carefully skeptical, but not unnecessarily cynical. You accept doubt in your mind and amongst your colleagues and within yourself with a gentle smile. And you practice the known medicine of the time as best as you can with a clear understanding that today's physiological truth is tomorrow's target of laughter. And more importantly, of course, in the meanwhile, as you wait for knowledge to improve, you enroll patients, not in bad, naughty, silly trials, but in high quality, well-designed, suitably powered, randomized controlled trials, so that the clinical effect of physiological concepts on patient-centered outcomes can be properly and empirically tested, and patient care can, on average, be improved. And how lucky are you that you are such doctors? Thank you very much.